It is a hyperinsulinemic, insulin resistant condition. Sorry, she froze again. Oh. So the other one, the other important point to remember on PCOS is that it's associated with significant risk. And I'm going to go over that. It's so important to know that these are young women, young girls who have the potential to have significant risk in their life. So it's very important to know what their risks are. And also the very important thing to understand is that we can mitigate these risks by just lifestyle and dietary changes. The key characteristics that now is what we understand should be a part of the diagnostic criteria is ovulation dysfunction, hyperandrogenism, and polycystic ovary features in the ultrasound. So these are the three current diagnostic characteristics that we use for diagnosis. Again, because this is a complex syndrome, none of the experts agree on how should the diagnosis be made. However, they agree on certain points. One is that the diagnosis should be made using hyperandrogenism, ovulatory dysfunction leading to menstrual irregularity, and the presence of polycystic ovaries. But the combination of how this is done differs according to the different diagnostic schemes. So that's important to know. That's one thing is they agree that these are the three symptoms or signs or symptoms that we use. The second thing they agree that the diagnosis of PCOS is the diagnosis of exclusion. So we have to exclude other causes, secondary causes of the same symptom. And the third thing they agree, most of them agree, that they don't recommend diagnosing a young girl, a young teenager who's just entered menarche in the first 2 years. If her cycles are irregular, you don't diagnose PCOS that early because the diagnosis, that symptom overlaps that what is seen in that age group. The physiology is similar, so you don't include. So those are the things they agreed upon. So let's look at the criteria that these three different diagnostic schemes are the most popular ones, but what is used currently is the center one. That's why I've highlighted it. The Rotterdam criteria is the one that's currently popularly used. So NIH came out in 1990, and that's what all my years of practice was NIH criteria. It was very strict. It was that it requires the presence of hyperandrogenism. It requires the presence of ovulatory dysfunction. That means menstrual irregularity. It did not include polycystic ovary. So if you look at this criteria, there are only two ways a patient could be diagnosed, two different permutations that a diagnosis of PCOS can be made. One is that the patient has hyperandrogenism and menstrual irregularity. So she's got PCOS. Or she's got, because these two are required criteria. She's got hyperandrogenism, she's got menstrual irregularity, and she's got polycystic ovary features in the ultrasound. So those are the only two permutations under the NIH criteria. But if you look at the Rotterdam criteria, it is all inclusive. In this criteria, experts agreed that hyperandrogenism is not required. It can be there. Ovulatory dysfunction is not required. It can be there. And they included polycystic ovarian feature in the ultrasound. So if you look at this diagnosis scheme, there are 4 permutations. One is, because remember, the other thing they all agreed upon, that all you need is more than 2 signs or symptoms to diagnose somebody with PCOS. Remember I told you, they all agreed that all these are the 3 signs or symptoms that should be included. They all agreed that more than 2 symptoms or signs should be there. They all agreed that young girls should not be, and they all agreed it's a diagnosis of exclusion. So if you look at the Rotterdam criteria, you can have a patient with hyperandrogenism and ovulatory dysfunction, which is menstrual irregularity, so she's got PCOS. Or you could have somebody who has all 3, so she's got PCOS. Or you could have somebody with just hyperandrogenism and a polycystic ovary, she's got PCOS. Or you could have somebody with menstrual irregularities and the presence of polycystic ovary, she's got PCOS. So there are 4 permutations. So it's more inclusive. And that is why the experts believe that the prevalence of PCOS is shot up. Androgen Access, the AES Society, came out in 2006 with their guideline. They said the patient should have hyperandrogenism. That is a requirement. You don't need to have menstrual irregularities, and you don't need to have presence of polycystic ovaries. So based on this criteria, there are 3 permutations. One is either they should have the hyperandrogenism with ovulatory dysfunction or menstrual disorder. That's one. Or they could have hyperandrogenism, menstrual disorder, and polycystic. That is 2. Or they could have hyperandrogenism and polycystic ovary. That is 3. So this has 2 permutations. This has 3 permutations. The current commonly used diagnostic criteria, which is the Rotterdam 2003 criteria, has 4 permutations. I hope you all understood that. This keeps changing, but this is the current one. Earlier we had obesity included. I don't know how many people remember that. And we had infertility included. And we had elevated LH-FS ratio as a part of diagnosis. That is removed. We had both ovaries should have increased follicles. That has been removed. I'm going to come to that. So talking about each characteristic. So the first characteristic that they included is ovulatory dysfunction. So it presents itself with menstrual irregularities, right? The most common symptom that they come with is my cycles are 35 days apart. So we all know that normal menstrual cycle is anywhere between 21 days and 35 days. So anything more than 35 days apart is abnormal. Anything less than 21 days is abnormal. So when the cycles, their most common presentation is my cycles are more than 35 days apart. And we call it oligomenorrhea when there is less than 9 cycles in a year. Then the next common symptom is I missed my cycles. It's amenorrhea. That means she missed it for 3 months or more. He says amenorrhea. Then the third presentation, which is less common, is cycles are coming less than 21 days apart, and that is called polymenorrhea. And you all know, you all are clinicians, you all know all these symptoms is also present in so many other diagnoses. So we'll come to that. So we got to rule out all the secondary diagnoses. So the important, which I want to emphasize, is that when patients, especially young girls, or even sometimes young adults, when they present with your menstrual irregularities, their perception of irregularity be totally incorrect. So it's extremely important for us to have them document what is really going on. And this is a menstrual record that I got from the internet. And so and nowadays it's on the iPhone, it's on the iPad, and it's on the internet, so she can document it there. So basically what you want her to do is write down, jot down how much of bleed, when did the bleed start, how much is she bleeding. That's all you need. And you need 3 months history. So let's say this young girl period started on January 1st. And in this record, they say S is for spotting. So you can say S here, and then she had spotting there, then a normal period, and then heavy period. It ended up on the 8th. And let's say her next period started on the 21st. Some of them will inaccurately come and tell you my cycles are closer. But if you look at the record, it started on the 1st and the next period started on the 21st. So it is normal cycle length. But if she calculated from the end of her bleeding and the beginning of the next cycle, she's not correct in her assessment. So that is why it's so important. Another reason why this menstrual record is important is you can see whether the heavy bleeding boxes are getting more as she gets older, because that's to think of secondary diagnosis. Or you're looking at, now she's getting her period, it was always 21 days, and now her cycle is starting 31 days. That is a shift. So again, you're thinking, what's going on here? Obviously, I'm going to rule out something else. So it's easy to have a graphic, a visual graphic about what's going on so that as she comes, and the most important thing to remember that we need to follow them up that regularly. So when you see that graph and say, oh, this is changing, so let's, you know, you know, do other tests to find out what's going on. Then the secondary characteristic that that is included is hyperandrogenism. So the experts agreed that it could be a clinical diagnosis, it could be a biochemical diagnosis, or it could be both. So clinically, if you want to diagnose hyperandrogenism, is excess facial hair, acne, balding, male pattern. You all know what a male pattern distribution of hair is. You know, you have hair under the chin, over the lip, around the areola, between the thighs, between the buttocks, lower back. This is all extreme hirsutism. And then signs of insulin resistance, which is associated with hyperandrogenism, which is, you know, central fetal obesity, high blood pressure, the, you know, skin changes, and even glucose parameters go off. Then the other diagnosis is biochemical. What the experts recommend is when a patient comes to us for the first time, it's best to run a biochemical on them to document how high their androgen levels are. So biochemical test, what they recommend is what we find is that there's an increasing androgen level. And we'll go over what tests to be ordered, but that is what is included in this diagnosis criteria. The last characteristic is this is a picture of the, you know, how the terminal hair is when they are hirsute. If it's a normal physiological hair that runs in the family, it's not like this thick, dark hair. This is hyperandrogenism. So what is the characteristic of polycystic? What is inclusive in our Rotterdam criteria? 12 or more 2 to 9 millimeter follicles in one or both ovaries. So earlier they had said both the ovaries. Now it's one or both. And they also said it need not just be follicles. It could be just the volume is big. Again, one or both ovaries. So more than 10 cubic millimeters, one or both ovaries is again a suggestive sign of PCOS. In the beginning, when they brought this criteria forward, they did a few histopathological studies on these ovaries, and they found that they coincided with histopathology of PCOS, and that is why this diagnosis was, this characteristic was included. However, after many years, we found out that 50% of normal cycling women meet this threshold. So in 2018, the International Evidence-Based Medicine Group recommended that instead of 12, we should use 20 or more follicles in each ovary for the diagnosis of polycystic ovary. This is one of the diagnoses. You can see how the cysts are, but if you want to look at a very typical PCOS ovary, it is like like a ring of pearls. It'll be like all these follicles are on the periphery, and yes, the ovary will be enlarged because theca, the stroma, is thickened. What are the risks associated with PCOS? Too many. One is anovulatory infertility. So these patients have hyperinsulin and insulin resistance syndrome, which causes hyperandrogenism. Hyperandrogenism causes obstruction of proper ovulation. So they have infertility. The other thing they are at risk for is pregnancy complications. They are prone to have pregnancy-induced hypertension. They're prone to have preeclampsia, gestational diabetes, preterm delivery, early pregnancy loss. That's a lot. That's a large group of risks in pregnancy complication. So the gestational diabetes is because of the insulin resistance. The loss is also because of insulin resistance. That's what experts believe. And the other ones, the pregnancy-induced hypertension, preeclampsia, and preterm delivery, they think is probably because of this low-grade chronic inflammation that these patients have. Endometrial cancer is another risk for these patients. So when patients have oligomenorrhea and they have maybe 4 or 5, less than 4 cycles a year, that means throughout the rest of the time of the year, they're making estrogen. So estrogen is mitogenic. So bombardment of the endometrial lining with just estrogen over and over again over a period of years causes, thickening of the lining, endometrial hyperplasia, endometrial polyp, and then cancer. So the incidence of endometrial cancer in these patients 2.7 times higher than women without PCOS. And the lifetime risk is about 9%. So it's pretty high. So that's important to know that they have this risk and we need to mitigate that. The other risk factor that is found in them is type 2 diabetes, again, because of insulin resistance. And then also habits, poor eating habits, poor exercise, lifestyle. The other one that is they're at increased risk for sleep apnea. And this could be because of this weight gain, and they have, because of metabolic syndrome, they have central fetal obesity. So that causes obstructive sleep apnea. So it's extremely important to elicit that history about their sleep pattern, because if they have, studies have shown that most significantly obstructive apnea, most significant is their glucose abnormality. So they are linked. The other important thing is dyslipidemia. They tend to have a high LDL, and they have the small particle LDL to be higher, which is, we know, at higher, that presence of that dense particle is linked to higher risk of heart disease. So they have that. They have elevated triglycerides, and the HDL is low. And because of all that, because of type 2, because they are at risk for heart disease. They also tend to have elevated CRP levels, and that could be also another added risk. The other risk factor is obesity. And again, no one knows whether it's a comorbidity, or the experts sometimes differ, whether it's a comorbidity or whether it is a cause of PCOS. I mean, the obesity, their lifestyle cause it to trigger, like a trigger factor. Then metabolic syndrome, which again is hypertension, weight gain, glucose abnormalities. Then non-alcoholic fatty liver, or even NASH, is associated with PCOS patients. And but experts don't recommend that we evaluate ALT levels on a regular basis in these patients, because the risk of them having this is very low. Sadly, depression and mood disorders, anxiety, depression is common. It's 60%. And they looked at to see whether it is present because of infertility, or is it because of obesity, or is it because of hirsutism? No, it is just high. So it's very important for us to actively evaluate patients for depression and anxiety disorder when they come to us. So what are the suggested evaluation? Like any patient who comes to us: history, physical exam, obtain certain lab tests. When we do the lab tests, we are looking to document hyperandrogenism. We are looking to rule out secondary causes, and then we eliminate, and then we want to evaluate any risk factors, currently there in the patient, like metabolic syndrome. And then in the ultrasound, we are looking to see whether does she have those features at 20 follicles or more. And then there are some optional tests to consider based on your suspicion when you see them in the clinic, when you listen to what they're saying, should you run these tests. So we'll go over that. So let's go with the history first. Is the history. So the thing when the patient comes, we all know you'd ask them, when did it start? So it's extremely important. When did it start and how fast did it go? So let's say a patient comes and says, I was all okay, and last 3 months this whole thing grew. That's not PCOS. That in your back of your mind is saying, oh, this must be a tumor, because PCOS is not sudden and not aggressive. Then the other thing we want to ask, is there any recent body weight? And we all know the obesity is comorbid, or it could be even triggering factor. So you want to ask her, has anything recently changed in body weight? So BMI is important. So The other one you're looking for is menstrual history, because that's very common in these patients. So whether it's oligomenorrhea, or remember also, if she has amenorrhea, it could be other than just PCOS, it could be other conditions that's causing it. Fertility issues. The important history that some of us miss, that you need to remember to document, is that if a patient says, I'm not wanting to conceive, but been married for 5 years, and we don't use much contraception, we just use safe method, or sometimes we do the pull out. But then we ask her, did you ever accidentally get pregnant? And she says no. That's kind of something to keep in the back of the mind, because that could be that this patient is not ovulating, because she's been having pretty much unprotected sex, but she didn't get pregnant accidentally. So that's one history to get. The other history that you want to know is that if she did get pregnant, did she have an early loss? So because you're suspecting PCOS and now she's had early loss, so her risk is up here when she's planning to become pregnant again. Then you also want to be looking under this fertility issues, this pregnancy, was there any pregnancy complications? We just talked about it. Ask her if she had any of those. Then medication history is important. What you're looking for is, this is a young girl, sometimes may take, performance and anxiety, anabolic steroids, so glucocorticoids are given so they can get hirsutism, weight gain because of that. So it's important to get that history. Sometimes patients use Rogaine for, balding. That can cause some hirsutism, or, drugs like phenytoin can cause. The other thing you look for is family history. So if they have a family history of cardiovascular disease, especially a man in the family who had heart attack less than the age of 65, that you're putting your patient at high risk. Or if you have a family history of a woman in the family who had a heart attack at the age of 50 or less, that's also an increased risk. And any history of diabetes, any history of infertility, any history of pregnancy losses in the family. All these are important things to get it from the history. Then we talked about sleep hygiene. Sleep is disturbed in many of these patients, sleep apnea. So ask them. But in this Bay Area, I think the question you got to ask is, how many hours of sleep do you get? They may be in normal, weight PCOS patient who works so hard and she barely sleeps. So that is an important factor to note, because if they don't sleep enough, like 7 hours, they can release cortisol, the stress hormone, and that can cause central fetal obesity and then a whole cycle of everything. Stress factors are important to document. Is she stressed at home? Is the husband not treating her well, or is the stress at work? Or the child is sick. Is she stressed for that? So that's important to this thing, so that you can think about how to direct her so that we can help her minimize her stress. And then it's important to get a 24-hour dietary recall, because especially when a patient has a change in body weight, or you find this family history of diabetes, you want to know, what is she doing with her diet? It's so easy to get. You just ask her, go backwards. Let's say it was an afternoon appointment. Say, what did you have for lunch? Just jot down in your mentally what she ate. Go back. What did you eat for breakfast? What did you eat for dinner last night? You're just trying to get an idea as how she eats, and so you kind of calculate how many carb units she's getting. But to know that the dietary recommendations are not special for PCOS, but we need to know how much calories she's getting. Then depression question, as I told you, is important, because that depression is pretty high. Mood disorder is pretty high in these patients. So especially if there's a young girl coming in with hirsutism, it's best to give them this questionnaire. So it's so easy to have. Most of us have these depression questionnaires in their offices. The OBGYNs, we use the Edinburgh screening, or we use the PH9, the Patient Health Questionnaire 9 questions. And then it'll give you a kind of a number and tell you what she has and what she doesn't have. This is with the evaluation, we talked about the history, and now we're coming to the physical exam. This is what we see. We see a little central fetal. This is to do with insulin resistance. central fetal obesity, blood pressure is high a little bit, BMI has gone up a little bit, waist circumference is up, um, and this darkening of the skin here. You can get it under the nape of the neck or under the armpit or between the groin. That's the and then for hyperandrogenism, you can see acne, hirsutism, balding. This is a closer look of the skin changes in metabolic syndrome, and is the acanthosis nigricans. And here it's in a better picture of the acne and hirsutism. So the thick, coarse terminal hair, and that's what is found in them. So coming to the laboratory, so we finished the physical, the history, the physical, now the lab. So the first thing we want to do is to document that does she have hyperandrogenism, biochemical. So most experts recommend that we need to get a free testosterone that is most accurate. However, getting a direct free testosterone level is notoriously inaccurate unless you have a good lab, and some of the endocrinologists have a lab in their office and they run the accurate test. However, most of us order total testosterone and sex hormone binding globulin, and then the lab calculates the free testosterone. It's pretty close to the actual free testosterone determination. The next is we want to exclude other causes. So the number one exclusion is the adult onset congenital adrenal hyperplasia due to the 21 hydroxylase deficiency. So when this deficiency exhibits itself early in life, like in childhood, like a baby, it presents itself as ambiguous genitalia. You can't tell if it's a boy or girl. But when it exhibits itself later in life, it has the same symptoms like PCOS, irregular periods, hair growth. So the way is advisable is to obtain the 17-hydroxyprogesterone level early in the morning in the early follicular phase. The follicular phase is the beginning of the cycle, menstrual period. That's the follicular phase of the cycle. So menstrual cycle day 3 or 4, early in the morning is the best time to run this. If we do it, how hormones are differ according to the cycle that the patient is on. So this has to be done cycle day 3 or 4, early in the morning. And if the level is less than 2 nanograms per ml DL, then it's normal. The TSH is again hypothyroidism, can present itself with same thing, irregular cycles and mild hirsutism. So do that to find if it's normal, do a prolactin level. Elevated prolactin levels can present with amenorrhea or oligomenorrhea. The last is evaluate for metabolic abnormalities. So most experts agree that 2-hour GGT is better than a fasting. So you give them a 75 grams, they go fasting, you give them a 75 gram load, get a fasting blood sugar, and then get 2 hours later. It should be less than 100 fasting and less than 140 after 2 hours. Hemoglobin A1C should be less than 5.7. And most experts do not agree with fasting and hemoglobin C. They would recommend a 2-hour GTT and a hemoglobin A1C just to see where she is. And then the lipid panel. The lipid panel is the total cholesterol, LDL, HDL, and triglyceride. And the last, I don't know if you can see my slide because I can't see the bottom. It's the highly sensitive CRP. And again, not everybody recommends it, but it's a good thing to do because Asian Indians have a higher risk of heart disease. So getting the CRP level kind of will give us, and then if she's a PCOS patient, if the level is high, you need to have more lifestyle changes in your thinking of, how do you prevent this patient from getting a heart disease. So remember the last part of my slide was we could do an optional test if you suspect something in your history or your physical exam. One suspicion is if she comes with, you see the diagram on your menstrual calendar, and the cycles are getting lighter and lighter, more spotting and more far apart, either she's pregnant or she's got primary ovarian insufficiency, where her follicles don't function. And before the age of 40, she becomes menopausal. Or she's got, the hypothalamic hypogonadism um, um, syndrome, where the pituitary gland is not functioning well. So you run a gonadotrophin level where when the hypogonadism is the problem, their FSH and LH is low because the pituitary is not producing the hormone to stimulate the ovary. So it's low, and of course the estradiol level will be low. But if it's primary ovarian insufficiency, the ovary is not working fine. So the hypothalamus is bombarding the ovary. Hey, come on, do your job. So the FSH and LH is high in that. So FSH will be more than 20 in this case, and the estradiol level will be low. Then the other one is fasting insulin. That is recommended if somebody has a severe stigmata of metabolic syndrome, and endocrinologists, reproductive endocrinologists do a fasting insulin level in women who are going to undergo ovulation induction. The 24-hour urinary free cortisol excretion test or low dose dexamethasone suppression test is done for patients with suspected Cushing syndrome, and usually their features will be, moon phase, the stria in the abdomen. So at that time, and most of us just refer patients to the endocrinologist when we suspect all these things. So in the differential diagnosis, before that is the ultrasound, labs and ultrasound. So the last thing about our evaluation, we said the history, the physical, the labs, and then the ultrasound. So just repeating the same thing, it's 20 or more follicles at 2 to 2.9 millimeters or increased volume. But this is also needs to be done on the early follicular phase. So if you did it later on, and if you find a 10 millimeter follicles, we don't know whether this patient is about to ovulate. So you'll have to repeat it. And then again, to remember that only one polycystic ovary is sufficient for making the diagnosis. We don't need to have both. Another important thing that the ultrasound does, remember we talked about patients who are having very infrequent periods. They could, just have no progesterone to protect their lining. So they get a thickened lining, hyperplasia, polyp, cancer. So when you do the scan, the radiologist looks at the lining, so it gives us information. However, if you do the scan in the middle of the cycle, then the lining is thickened because they quote, the endometrium is getting ready for a possible pregnancy. So you cannot conclude anything when the ultrasound is done any other time other than the cycle day 3 or 4. Do you get that? And sometimes it's hard to do it on cycle day 3 or 4 because she's missed a cycle. So you just do it. You don't even know what cycle day she is. So then that's okay. We just have to repeat the test. That's all. The differential diagnosis. So we went over while I was doing the labs. I told you about, the congenital hydrogen is a big mimicker of PCOS. So we do the 17-hydroxyprogesterone. This is because of a 21-hydroxylase deficiency. Then in the history, we ask, are you taking any drugs? So then we know she's got exogenous androgens. So we can document that. In the history, if she says, oh, my symptoms came out that fast and it looks pretty, severe hirsutism, then you're thinking about it in secreting tumor, and then you do an androgen level, it's way beyond 200. Usually for patients with PCOS, their levels are mildly raised. In Cushing syndrome, again, you can see the features. If you suspect, and you do the 24-hour urine cortisol or the dexamethasone suppression test. And then the other thing you're looking for a differential diagnosis, we talked about primary ovarian insufficiency with the gonadotrophin level, the primary hypothalamic hypomenorrhea, you're looking at that. And the thyroid test, you do the prolactin disorders. Acromegaly is, again, facial features, jaws big hands, and you do the appropriate test. Now we come to clinical consideration and the treatment recommendations. So I'm going to be dividing into 3 clinical scenarios: not attempting to conceive, increased hair growth, attempting to conceive. So again, remember, all these patients, whether they're attempting to conceive, they come to you for hirsutism, they come to you for wanting to conceive, all of them need this lifestyle modification mantra. It's so important that they understand the importance of diet, exercise, and behavioral changes. And studies have shown that if the physician shows interest and takes time to stress on that, patients tend to follow it. And also to remember that in order for anybody to change their whatever they're doing and to make it a habit, they have to do that change for 90 days. So if you can be kind of call her up, and just like how the South Asian Health Center does, are you on track? Do you have a problem? How can we help you? So that is important. So 90 days. And then the other thing to remember in this lifestyle modification is that what is the blockage? Ask her. It could be something so simple. Dr. Menon, I can't get up in the morning to do that. Okay. We are advising to do 30 minutes 7 days a week, but can we break it up? Can you do 10 minutes here, 10 minutes there, 10 minutes there? Can you walk up the stairs when you're at work before lunch? Can you, park the car far away and walk to your office? So when we actually offer these options and choices and make her think, they appreciate that they know that you're making it a big point that this has to be done. It's important. And so that's one thing to do, is to give her all these little things. And then also important to tell her that women who stayed with exercise and made exercise a habit were the ones who were shown to do their exercise early in the morning, or do the exercise before they come home, but after work. So they go to the gym, does the exercise, come back. Because once they come home, or once the family wakes up, they don't do exercise. So it's important to tell her that that's how this thing. And also, it's a it's a little like a carrot stick. You tell her that if you exercise and if you eat right, your child will watch you and will change his behavior. So what you do really, really helps the entire family. The other thing about diet is there's no exclusive diet for PCOS. What they found is just calorie. So calorie is a calorie is a calorie. So whatever she's eating, as long as she sees a dietitian, we have Projecta here. I'm so thankful that she's here. So she can tell, this is what I want to eat. Okay, if you eat this is how many calories. So do you still want to eat it? So it's basically you have $100 to spend. And how are you going to spend? You buy one thing for $100, or do you want to buy 2 or 3 things? So that's how she barters and decides what to eat. So it's not restrictive. So when you restrict a patient, like, you're going to get diabetes, you can't eat your jalebi, she is going to persist. She wants to eat a jalebi. So instead you can say, you know what, you can skip this and eat a quarter of a jalebi, eat it slowly. But so she satisfies her desire to eat something. So remember, it's calorie, 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 nothing to do with, this should not be eaten or that should not be eaten. So diet, exercise, and behavior. The other behavior change that is very important for these patients is sleep. So why is she not sleeping? Is she stressed out? Is it, if it is to do with abdominal fat, exercise will help so she can sleep, or meditation helps to reduce the stress. So it's important to send her to a meditation class. There are so many online. So it's important to, get it going. And sometimes they'll say, I don't have time for meditation. So even 10 minutes is enough. So when you look at the goals, so look at the ATP, this is the Adult Treatment Panel Revised Guideline. They say to trim the waistline less than 35 inches, obtain the ideal BMI, which is 23, drop triglyceride less than 150, increase the HDL for more than 50, reduce systolic less than 130, and diastolic less than 85. And the 2-hour glucose should be, fasting less than 100, and hemoglobin A1C 5.7. But I think it's prudent to use Dr. Ronesh Sinha's guideline. And he calls it, I don't know how many of you have read this book, South Asian Health Solution. Dr. Ronesh Sinha is one of the physicians in the Bay Area, and he's done a lot of research on this and helped a lot of patients. So he mentions what is called a metabolic 6-pack. It's a nice way to remember. It's a metabolic 6-pack. What is your six pack? Waistline 31 inches instead of 35 inches. Drop the triglyceride to less than 100 instead of less than 150. HDL should be more than 60 instead of here it's more than 50. And the systolic should be less than 120, diastolic less than 80, and the 2-hour glucose same as this guideline. And he also added the highly sensitive CRP. So to me, it's like, if you focus and shoot for the moon, but drop between the stars, you're still a winner. So if you shoot for these guidelines, but yet you fall here, she's still a winner, right? So this is what may be a good thing to do. And then the other thing, now she's come with you with menstrual irregularity. So we need to be thinking of protecting her endometrium and preventing unnecessary pregnancies. So the goal mainstay of therapy is combination low dose orlistat. There's this fear that they have this metabolic syndrome, they have this hypertension, they have this chance of having diabetes. Will this increases? And so far, there is no clear-cut study showing that it increases all these. So we could still use the recommendation, still use it, but use low dose. So using 20 micrograms of estrogen may be better than a higher dose if possible. But sometimes you need to use a higher dose of estradiol if the patient cannot be controlled with irregular bleeding. And I'll come to detail about the OCPs in a later slide. The insulin sensitizing agents like biguanides were known to show improvement in the menstrual cycle when they were given to patients with pre-diabetes. Initially, many of us started using insulin sensitized agent for patients who are trying to get pregnant, because these patients started having regular cycles while they were on metformin and they got accidentally pregnant. So somebody did a study and said that the pregnancy rate was high. So we started doing that. But then there was another study which showed there was no change. In fact, there's more successful pregnancies when we use lifestyle and dietary changes than just using metformin. So insulin sensitizing agents are not recommended to treat menstrual irregularity. What do you do with dyslipidemia? Again, emphasis on lifestyle. Remember, again, these are young patients. They may tell you, Dr. Menon, doctor, I'm not interested in having pregnancy right now, but they are down the road. So you want to be sure that she has a healthy pregnancy. So focus on lifestyle modification. Listen to you if you make that a big priority. Statins, well, if she has a significant family history or she's significantly morbidly obese, you may have to start statins. Statin does not change the HDL though. It does not increase the HDL. It does not change any glucose parameters. And it does not decrease the CRP. Diabetes prevention. Again, these patients are at high risk for diabetes. So diabetes prevention is important. Same thing, lifestyle modification, eat right. There are some studies saying metformin could prevent a patient from getting diabetes if she's pre-diabetic. However, it is so important in these young women to try lifestyle modification changes, because that does not give you any side effects. So it's important to do that. The next group of patients that come to us for treatment due to PCOS is hirsutism. So the important thing to know about hirsutism is that you do not delay treatment. People have done studies that when physicians take time to find out that, well, what is the cause of a hirsutism and try to figure out before you give the treatment, these young girls have depression. And some of them even try to commit suicide, because for them, that's a no-no, having acne and hirsutism. So it's important not to delay treatment. And again, even though they're young, they're coming to you with hirsutism, do spend time talking about lifestyle changes, because they're also at risk for all those chronic conditions. And also tell them that weight loss decreases the male hormone level in the body, and thereby hirsutism improves somewhat. So it's important to mention all that while you start treatment. So what do you give for treatment? The gold standard, the number one treatment is combined oral contraceptive pills. This, what it does, it reduces the size of the ovary, so reduces the ovarian androgen production. That's number one. It increases the sex hormone binding globulin, so there's not much free testosterone. So free testosterone is the biologically active androgen. So if it's bound with a sex hormone binding globulin, which is lowered in patients with PCOS, the combined hormone concept increases that. So there's more bound androgen. So not much active, bioactive androgens. So the hirsutism goes down. However, the FDA has not approved combined oral cancers for treatment of hirsutism, just to let you know. But that is the number one. And so the important thing also to tell these patients is that hirsutism treatment does not give you cure. It is just slowing down or improving it somewhat. And that she has to wait 6 months to see any change because the hair life cycle is 6 months. So you start a treatment now, you have to wait 6 months to see a change. So we normally start off with OCP, look for side effects, and if nothing, ask her to come back in 6 months. If she's not happy, it's not your happiness to seeing her. She has to be happy that her hirsutism is somewhat improved. But if she's not happy with the outcome, then add anti-androgens. So in this country, we have the spironolactone, we have finasteride, we have flutamide. Most commonly is spironolactone. We don't use finasteride. I mean, some dermatologists may use, but we don't as much. And flutamide is not used because it has severe hepatotoxicity. Cytopyrrhine acetate is not available in US. Eflornithine is a cream that is used for facial hirsutism. It reduces facial hirsutism by suppressing the L-ornithine is an enzyme that creates the differentiation and helps the growth of hair follicle. So when they apply it, it had to apply twice a day. It slows the growth. So we're giving the combined, which the pill that also decreases, eflornithine that also decreases, then you see a much decreased, hair growth. But multimodal therapy is what is most commonly needed in these patients. So you give them combined, you give them anti-androgen, sometimes add the eflornithine, and then you also have them do mechanical hair removal. So mechanical hair removal could be either chemical or plucking or shaving or, what do you call? I forgot the name, where you use the thing to pull it. This, when you go to the hair, the facials.
The wax?
Waxing, yes. All that, people are worried that if you do that, the hair growth will be faster or thicker, and it's not true. No, research doesn't show that, so it's okay to do it. However, you have to repeat it, right? Laser and electrolysis have been studied, and it's a better mechanical removal method because it tends to destroy the hair follicle. However, when you do the laser treatment, the hair is on different cycle. So you may get one which is almost the end of its 6 month, and you may not get one which is in the beginning. So that's why you need to have a repetitive this thing, and it's expensive. So that's about laser. And for patients who have dark skin, sometimes the laser is absorbed by the skin and you get burn there. So that's something to tell the patient. Insulin sensitizing agents is known to modestly decrease hirsutism because of when you give the insulin sensitized, the insulin sensitivity goes up, so the hyperinsulin state goes down. So there's no so much the sex hormone binding globulin level goes up. So there's not that much of free circulating bioactive androgen. So that is why it goes down. However, it's not indicated for hirsutism because the response is very modest. So talking about the drugs, there's no difference clinically between a moderate androgenic progestin with low androgenic potential progestin. Because, the very new OCPs have these very low androgenic potential um, progestin in them. They are more expensive, and unfortunately, some of them have the same activity like spironolactone, like drospirenone can also cause elevated potassium level like spironolactone. So when you're adding the second therapy, like you started the OCP and then you want to add anti-androgen spironolactone, you want to be sure that they don't have the new generation progestin, the low androgenic potential progestin, which can also do the same action of increasing potassium level. So the common preferred treatment is a monophasic for a couple of reasons. One is it's easy for patients to use. It's just one, there's no up and down. It's not multiphasic. The other thing, which is also important, these people have irregular cycles. And if she wants to go, for a wedding or to the temple and she doesn't want to have a period, it's very easy for her to just continue the active pill. So it has no up and down thing in it. So that is one of the reasons. And also it's very important to give her the lowest dose estrogen so they don't have the side effects of hypertension or possible of having increased risk of diabetes. Oops, sorry. Can't see my bottom of my slide. What does it say? I can't see the bottom.
So it said follow up 3 to 6 months apart.
Yes. Yeah. Sorry, I'm going forward here too fast. So yes, it's very important because first of all, when we start a patient on, sometimes it's so severe that you want to start them on anti-estrogen and birth control pills. But when you do that, it's best to start on birth control at least for 1 month and see how she's got any side effects, and then add the anti-androgen if you want to do both at the same time, because it's such a severe and you don't want to do, stepwise. But then you need to be sure you follow them up in 1 month or 3 months after we start these new drugs, and then every 6 months just to see how the effect is. Now she's blocked. Okay. So here the women who are trying to conceive. Why is she saying this? Aim to prevent long-term risk. That's the main thing. She's coming to, I want to get pregnant, but again, in your head, you're saying, I want to prevent long-term risk, because even though she is normal weight and not obese, she's got a risk for diabetes when she gets pregnant. And it's actually very difficult to manage her gestational diabetes if she gets diabetes. So it's important to focus on weight loss, exercise, to increase insulin sensitivity, improve pregnancy rates, and reduce high-risk pregnancy. So, your aim is to prevent long-term risks. The first line of therapy is letrozole. Letrozole is an anti-aromatase. So it's actually used for breast cancer, but this is an off-label use of letrozole. It has a wonderful outcome, and with the use of letrozole, we have much higher pregnancy rate than clomiphene citrate. So it's a small dose we use, 2.5 to 5 milligrams, and we stop it much before she ovulates. So there's no effect on the ovulation or the fetus or the mother. The current guidelines do not recommend the use of metformin in obese women with PCOS to achieve ovulation. Earlier, remember I told you there was a study saying that when we use metformin, they are higher, but someone did a follow-up study looking at two, one where patients were on metformin, the other would just exercise. In fact, the people who were exercising and dietary and lifestyle changes had a slightly better success with a live birth rate. It's not just pregnancy rate, it's live birth rate. The second line of therapy, if the letrozole fails, is either low-dose gonadotropin therapy or laparoscopic ovarian drilling. And most of us don't do laparoscopic ovarian drilling anymore because it's extremely expensive, it's invasive. We don't even know what the long-term consequences of ovarian drilling is. And so from the letrozole, we go to the endocrinologist will go to the low dose gonadotropin as a second line. And if that fails, they go to the IVF. And usually the IVF is the fresh frozen rather than, frozen cycle rather than fresh cycle, which is more successful. Oops. Oh, sorry. Boo-boo on me. Oh. So there, I think we finished the slides. Yeah. So we're coming to the summary. Hey ho. One thing is what is it? So remember, it's the most common endocrinopathy affecting women of reproductive age. It requires 2 or more signs and symptoms of diagnosis. The 3 characteristics that they now recommend that we should use. One is menstrual disorders secondary to ovulatory dysfunction. Number 2 is hyperandrogenism. Number 3 is presence of polycystic ovaries. And then to remember, just seeing polycystic ovaries in an adolescent is not predictive of present or future development of PCOS. The goal, again, is to prevent long-term risks in all clinical scenarios. And in terms of treating hirsutism, multimodal therapy is most effective than for treating acne. And then lifestyle changes and oral contraceptives are the mainstay of therapy for patients who are not wanting to conceive. And patients who want to go ahead with conception should be encouraged to change their lifestyle and watch their diet and to prevent high-risk pregnancy and refer to a gynecologist or reproductive endocrinologist. That's the end of my talk, and thank you so much for patiently listening to me. I do want to thank Dr. Shashwati Kale and Dr. Raj Gupta for giving me the opportunity to talk. And I want to thank my dear friend Meera Shah. She's one of the reproductive endocrinologists who is excellent team player. So if you are looking for a reproductive endocrinologist, I would have Dr. Meera Shah help you. I invited her to come in because if anybody had questions on PCOS and infertility, she's here to answer. And the other person I want to thank is Dr. Weingartner. She's a nutritionist from South Asian Heart Center. South Asian Heart Center is a wonderful service that the Camino Hospital is providing. Is because they have this whole setup for lifestyle changes and behavioral modification and dietary changes. So we just have to leave it to them and they take care of the whole thing. So I'm very thankful. I also want to thank my nephew, the young boy who helped me make the slides for me, and my son who helped a little bit of the slide. And thank you for listening, all of you. And I'm here to answer questions.
Yeah, so thanks, Prasanna. Just like your name, you made it all very happy for us. So it's always good to have a happy speaker and kept us attentive throughout the talk. So the first question is from Raj, that does the diagnosis of PCOS, is it associated with early mortality or morbidity?
They didn't see that. So there's all this suspicion or this worry that there is an increased risk because they see some premature cardiovascular changes, coronary artery changes. But when they actually looked at the studies, long-term prospective studies, it differed. But when you look at the cohort studies, when they look at the Nurses Health Initiative study, they saw that women with PCOS had slightly adverse. So it's kind of controversial. So no one has a consensus. So it's best to go one step more, saying that you do have a risk, your CRP is elevated, you have a family history of that, and you have PCOS, and I really want you to, to not to start drugs, but to get that lifestyle changed,
And just talking about lifestyle change, I see a lot of these young college students coming that when they are actually in college, their cycles are completely bizarre. And when they are resting on vacation at home, the cycles are normal.
Mm-hmm.
Right? So the labs we do, because the parents are worried, oh, she's not getting her cycles, what is happening? And the labs turn out to be normal. Then, considering all these Rotterdam criteria and the NIH criteria that you mentioned, is it required to have an ultrasound done on every such person, or is it okay to wait?
Good
How
question.
many?
Good question. Because again, so you'd ask the history. Is there a family history of diabetes? Is there a family history of infertility? So you're looking at all these risk factors and saying, should I, you don't want to worry the patient not necessarily, but you, and of course, and also one thing you want to tell, because when you have a patient who's young and who's got irregular cycles and they don't want to tell you they're sexually active. So you want to think of pregnancy in the back of your mind too. So and I says what I'll tell patients that I'm doing a panel for you, and it includes a pregnancy test. So I'm not saying that I don't trust you, but this is just a panel. It includes that, so that way you can run a test. But I'll let Dr. Shah also answer. But I think if she's having irregular cycles in the stuff, I talk about stress. I tell them about what are you eating. Sometimes they're not eating well. I ask them, are you sleeping well? So I ask all the other things that could be a potential reason why her cycles are getting. They don't sleep well. They are stressed out. They're trying to do so many things. They have become very athletic. They start running. So those may be simple things that we can modify to do that. But if she had those risk factors in the back of her mind, I'm saying, I don't think there's any harm running these tests because she's here from vacation, so I can, at least document that, at least of today, everything was fine, But you can tell her that, based on what I hear, that these may be the reasons why this is happening. But we do, yeah. Meera, do you have to add something?
Well, I think a pelvic ultrasound is really a critical part of the evaluation, because in my practice, I see patients with infertility, and oftentimes they get misdiagnosed with PCOS, and in fact, they have premature menopause. And it's not until you do an ultrasound that you can differentiate a woman who has irregular cycles because she's perimenopausal versus a woman who has irregular cycles because she's polycystic ovarian. So you can have the other phenotypic characteristics, but it's really the ultrasound that just differentiates those two things. So I do a pelvic ultrasound on all of those patients, and I think it can be really eye-opening to give you a sense of what is the underlying cause of their irregular cycles. And I was going to add, go ahead.
50% of women have that, just unless you're doing a 20 follicles ultrasound diagnosis for PCOS, right?
For younger women?
Yeah.
Yes, and that's why the Rotterdam criteria has shifted to actually meeting all three of those criteria in order to fulfill the diagnosis. So you have to have, irregular cycles, hyperandrogenism, either clinically or biochemically, and the polycystic ovary. So rather than, adults where you only have to meet 2 out of the 3. So they're a little bit more strict about how many criteria you have to fulfill if you're younger, because younger women are going to have a higher ovarian reserve, and you're going to see polycystic ovaries just by nature of the fact that they're young. And I wanted to just add something. Your presentation was outstanding. One of the, I think the important take-home messages is that the treatment of PCOS really should be multidisciplinary. We actually, they have a really nice model at UCSF and I used to work there, where we used to have a clinic for women with PCOS, and we had dermatologists sort of address the skin changes, the acne, the hirsutism. We had psychologists and psychiatrists focus on the mental health, issues, and then the reproductive endocrinologists who worked on the fertility aspect. So it really takes the whole team of multidisciplinary providers to provide the best care, because this is such a heterogeneous diagnosis, and it manifests in so many different ways. And, I have the unique opportunity to see women who are trying to get pregnant. So they're extremely motivated to make those lifestyle changes. So I often find that talking to them about dietary changes and changes in their, exercise regimens, they're really motivated to make those changes. And even a 5 to 10% weight change can take them from being, irregular in terms of cycles to completely ovulatory. And that can make a huge difference. also optimizing their health pre-pregnancy can minimize the risks of gestational diabetes, gestational hypertension. So I had this unique opportunity to really motivate these young women to make changes in their life that can change not only for their pregnancy, but their overall long-term health. And I counsel a lot of women also about fertility preservation. You know, one thing I see a lot in my women, and I would say about 10 to 15% of my patients at least have PCOS. And while their issue is not, you know, that they have their egg supply is poor, they clearly have a large egg supply. Their issue really is an egg quality. And I think that plays into the effect of obesity and high BMI on egg quality. So, you know, these patients can be actually very challenging to manage from a fertility standpoint because they have very high ovarian reserve but very poor egg quality. They also have a higher risk of miscarriage as well. So there's a lot of counseling that goes into their treatments, and specific treatments like you mentioned, letrozole, that is a lot more effective for these women. But when we're doing, I tend not to use the gonadotropins because if these women superovulate, they're going to have extremely high risk of multiples. So I typically, if I do 3 to 6 cycles of letrozole and it doesn't work, we move straight to IVF. And IVF in these patients can be extremely challenging because they're at very, very high risk for hyperstimulation syndrome, which is a condition in which they produce multiple follicles, they become very supraphysiologic with their hormones, all of their fluids start to third space, and they have a lot of electrolyte derangements that can be life-threatening. So we do have a lot of specific protocols in place for women with polycystic ovarian syndrome to mitigate those risks, but these can be a very complicated group of women to manage. So I would say for any of you out there who have women with this, you know, I think it's important to speak to either their OBGYN or a fertility provider just to talk about their fertility prospects, to talk about, you know, what their potential risks are in pregnancy, and to think about preserving their fertility as well if they want to have a larger family and they're starting their fertility journey potentially in their early 30s.
Thank you.
Yeah, thanks a lot, Dr. Shah. It's really good to have you also on this talk and get the endocrinology perspective. And that was an excellent presentation. Any other questions? I'll just review the chat. I think a couple of other people have joined. I had one more question about this prolactin level. So sometimes I also see sometimes the stress-induced hyperprolactinemia. Right?
You repeat it, early morning fasting, but repeat it.
So repeat it. Okay. So, and how soon, and is there a time interval or just few days later?
Few weeks later, right, Mira? I mean, 6 weeks, 8 weeks, whatever.
Yes, and I just tell them to do it fasting in the follicular phase of their cycle and to avoid any kind of nipple stimulation. Right. All of these things can elevate a prolactin level.
So to remember, most of the PCOS diagnosis is made on cycle day 3 or 4.
Okay.
You'll never go wrong.
Okay. Okay. Thanks a lot. Excellent presentation and wonderful.
Thank you so much for giving me the opportunity.
Yeah.
And thank you, Ganka, for coming. Did you want any questions on South Asian Heart Center? Anybody has?
No, I have their little cards that they've dropped, and I know about their meds program. So yes. I didn't know that there was a dietitian there. They do that the extra lipid panel and the LP little A they were doing with Quest. So, but now it's good to know that even all these PCOS patients can be sent there.
Yeah, they have the diabetes, excellent diabetes prevention program. That's why. So they've incorporated both. So yeah,
we do get referrals from both you, Dr. Menon and Dr. Kale. So really thankful for that. So yes.
Thank you, Dr. Menon and Dr. Shah. It was excellent presentation, and look forward to a lot of future talks. Thank you.
Yeah, and we have a future RPO member at Mira Shah.
Yes, I really want to make it sure we pitch for Dr. Shah to come to our meetings and also become a lifetime member. We have our semi-annual on 30th, and if you can join, that will be great.
And Raj, maybe she can also be a speaker.
Yes.
Yeah, she can be speaker, future speakers. So we do once a month. We have a CME panel where we evaluate all the future speakers and then go through the topics. So we'd love to have, if you want to present any topic, let us know.
And
Yeah.
maybe, Raj, we can have Prajakta speak on obesity or something that South Asian Wellness Center is doing, right?
Sure, absolutely.
We can certainly, I mean, when I was listening to Dr. Menon, the importance of lifestyle was really highlighted, right? And meds is meditation, exercise, diet, and sleep. And the recommendations that we make for our participants work in conjunction with, reducing insulin resistance and risk of diabetes and heart disease. So they would definitely benefit any patient with PCOS as well. The point that you made earlier, Dr. Menon, is trying to meet the patient where they are and find a sustainable baby step approach towards adopting lifestyle habits. That is the key to success, because anything drastic is is not long lasting. So that's the heart health coaching support and the regular follow-up that we provide. And yes, we have a fantastic registered dietitian as well on board, who very familiar with the South Asian diet and the nuances that we see in our participant profile, with living in the Bay Area and just kind of being overachievers and a high level of stress as well. So most certainly, we would love to present.
Yeah, I think it's important, like Mira said, everybody needs to be involved. Like when I was in private practice, you don't have a group of physicians. So we have a dermatologist we'll send our patients to, we have an endocrinologist, we have a reproductive endocrinologist. So we made our own team, but everybody in the team has to be saying the same thing: lifestyle. So if one of us drop the ball, I don't think we're going to succeed in preventing all these risk factors. Yeah.
All right. Thank you.
Thank you.
Thank you. Thank you.
Oops. Good night.
Good night. Good night.
Thank you. Bye. Bye.
Meet all of you.